What happens when the correct diagnosis is hidden behind a diagnosis that is also correct? Our patient had non-Takayasu arteritis involving the pulmonary arteries. Progressive pulmonary artery thickening seemed to fit perfectly with this underlying disease, but his clinical trajectory was telling us something different. Hi, my name is Sarah Busi, internal medicine resident at Orlando Health. My case today is a 48-year-old man with established Takayasu arteritis involving the pulmonary arteries, treated with immunosuppression, who developed progressive dyspnea and fatigue. He was found to have severe pulmonary and tricuspid regurgitation. Serial imaging demonstrated progressive thickening involving the right ventricular outflow tract and pulmonary arteries. At first glance, this seemed entirely consistent with his non-Takayasu arteritis. And that was the trap. Because of his established vasculitis, the progressive vascular thickening was initially attributed to inflammatory disease. An initial biopsy demonstrated fibrosis without malignancy, further supporting that interpretation. However, despite treatment for Takayasu arteritis, his clinical condition and structural abnormalities continues to progress. At that point, the question should no longer have been how severe is his Takayasu. The question needed to become how does Takayasu still explain the trajectory of his disease? The diagnostic breakthrough occurred during valve replacement surgery. Intraoperatively, the pulmonary artery was found to be markedly and unusually thickened, given the discordance between the presumed diagnosis and the clinical course. The surgical team obtained repeat tissue from the abnormal area. This time, pathology revealed MDM2 positive primary cardiac intimal sarcoma, an extraordinarily rare diagnosis in an extraordinarily unusual location, involving the right ventricular outflow tract and pulmonary artery. Why was it missed? There were three major contributors to the diagnostic delay. First, Takayasu arteritis provided a very plausible explanation for the imaging finding. Second, it was atypical anatomy. Cardiac intimal sarcoma is rare, and right-sided involvement of right ventricular outflow tract and pulmonary artery is particularly unusual. Third, the initial biopsy captured surrounding fibrosis rather than the malignant tissue. But perhaps the most important clue was not an imaging finding or pathology result. It was the trajectory. The patient subsequently received anthracycline-based chemotherapy and demonstrated interval reduction in tumor burden, leading to evaluation for definitive surgical resection. This case taught us an important principle: trajectory over anatomy. An undiagnosis may explain what an abnormality looks like, but it does not necessarily explain how that abnormality is behaving. When a patient continues to deteriorate despite appropriate treatment for an established disease, we should not simply intensify the same diagnostic framework. We should step back and ask whether we are treating the right disease. Thank you.